good that we have a lot of data, but I think a treating clinician has to keep in mind the person is treating, the patient is treating, his overall profile, and then take the decision about what levels he brings down the blood pressure and what drugs he uses. Now, just a couple of points about the measurement of blood pressure. It is important to check the blood pressure in various postures in every patient of hypertension, particularly in the elderly. There can be sometimes discrepancy in two arms because the disease in the subclavian vessels or in the arch vessels can be common in elderly because of atherosclerosis. The phenomena of auscultated gap and pseudohypertension are real, and we should keep them in mind. It's very important. Full bladder sometimes can increase the blood pressure, and when the patient comes to you, an elderly person, if his bladder is empty, tell him the person to void and take the blood pressure after 10 years, because many times there can be significant increase in blood pressure if the bladder is full. And if the person is having atrial fibrillation, there will be variation in blood pressure from beat to beat, and that should be recorded. There is some role of ambulatory monitoring, and the best clinical role is for correlating symptoms, suggesting postural or postprandial or drug-induced hypotension, or in those patients where the blood pressure is remaining unresponsive despite multiple antihypertensive drugs. Now, this is an example. This was a lawyer who came to me. He was an 80-year-old lawyer with hypertension, Parkinsonism, prostate, and he was referred that in the last couple of weeks, he started feeling markedly dizzy, and he has to sit, and ultimately he was forced to abandon his court appearances. And he used to say, whenever I have lunch, I stand up and I'm arguing a case. I'm not able to do so, but I'm all right in the morning time, and I'm also all right afterwards. And when his medication was amlodipine, Syndopa, and Temsulin, and when we did his blood pressure, 24-hour blood pressure monitoring, he used to have remarkable fall in blood pressure while post-lunch. And at sometimes post-lunch, there is a splanchnic dilatation, there's a diversion of blood to the GI, and also he used to be standing, and these factors used to call a marked postural hypotension. So we have to, in fact, give him a lot of advice about how to do things, when to have lunch and when to have his medication. Now, in an elderly person, once you establish the diagnosis of hypertension, you should also do an end organ assessment. It's extremely important because the elderly population is more likely to have other comorbidity. Looking at the cerebrovascular system, all history, whether there is any history of ischemic stroke, hemorrhage, any dementia, Alzheimer's, cognitive decline. Look at cardiovascular system, any history pertaining to coronary artery disease, hypertension, any chronic kidney disease. And it's extremely important in every elderly person, we should have estimation of the eGFR, should not go by serum creatinine, because a normal looking creatinine in a person of 80 years may indicate that there may be a significant renal dysfunction. And the choice of our drugs, how we adjust the drugs, depends on. So there should be a proper assessment about the end organ assessment, whether there are other comorbidities, also retinopathy, and other important thing is what is the overall quality of life. There may be a gentleman at the age of 80 who is very healthy, and there may be a person at the age of 80 years who is bound to the wheelchair. You have to treat these two persons with hypertension in a completely different way. We should look at the electrocardiogram, echocardiogram, and look at any cardiovascular evidence of left ventricular hypertrophy. Don't forget to check the fundus. Now let me give you an example. This is a 70-year-old male, 74 kilograms, tobacco chewer. He's hypertensive for 10 years on irregular treatment, have tried multiple drugs. There's a history of salt intake which is high, occasional alcohol. He also having a stable coronary artery disease 5 years. history of angioplasty 5 years back, ejection fraction 45 to 50, sinus rhythm, and no heart failure. Now here is a 70-year-old gentleman with coronary artery disease. Now, I want to make a couple of points. His blood pressure levels remain 150, 160, 170, and the diastolic pressure is around 70. Two important points I want to raise in this case. One is there a role of lifestyle modification even in this age group? Now, if you see, this person is obese, he has a high salt intake, he also has alcohol intake, and the point I would like to emphasize is at any age, non-pharmacological lifestyle interventions are important. Don't think that this person is 70, why to tell him to walk, why to tell him to stop his salt intake. The good non-pharmacological measures, lifestyle modifications remain important irrespective of age. The second point is, now this is a person where there is a diastolic pressure which is already normal or already on the lower side. Now, how do you treat the blood pressure in these patients? Now, those patients where there is hypertension, coronary artery disease, the best drugs to use is either a ACE inhibitor or ARB, beta blocker, and a diuretic. And the second line drug will be calcium channel blockers to be added. Now, the important concept to know is there is a talk about the J-curve phenomenon. The J-curve has been known for multiple years. When almost 3 decades back I was appearing for my DM cardiology exam, we had a short note on J-curve in hypertension. What is J-curve? The J-curve is that when you treat hypertension, and if the diastolic pressure goes beyond certain levels, and particularly if the diastolic pressure goes below 70, below 60, is there any harm you are creating? And there has been a lot of controversial trials, but few trials which tell that yes, there is a J-curve phenomenon, and particularly when you bring down the patient blood pressure below 70 in patients of coronary artery disease, there is doubling or tripling of the ischemic events. The stroke doesn't get changed, but the coronary events increase. And this is what was there in INVEST, TNT, but the value and the on-target trial gave contrary data. And this is what we have the new data from the Clarify registry, which has come in Lancet a couple of months back. And I'll just tell you the summary. In real life, patients with a stable coronary artery disease treated for hypertension, if you reduce their systolic blood pressure below 120 or diastolic blood pressure below 70, this is associated with increased cardiovascular events. So this tells that there is a J-curve phenomena in patients who are having hypertension and coronary artery disease. So be cautious in those patients when there is a blood pressure diastolic is 70, sort of don't reduce it too aggressively and get the diastolic blood pressure below. So sometimes when you try to cut down their systolic pressure, the diastolic also starts going down. So you have to use your best judgment and possibly not reduce the diastolic pressure below 70 in patients with coronary artery disease, the example which I showed you. And this is what the recommendations are, that in patients who have got a stable angina or coronary artery disease, keep the blood pressure below 130/80. Now this is another case example to give you another problem which we face in elderly person. Is a 70-year-old female, diabetic, hypertensive, common things which we see. Also has Parkinsonism, is on multiple antihypertensive drugs, and she is referred with evaluation of dizziness, unsteadiness, and occasionally she has fallen. The patient already goes to a neurologist, has a detailed neurological evaluation, biochemical evaluation, which are quite reasonable. And when you record the blood pressure in all the postures, you find that there is a remarkable drop of blood pressure from supine position to the standing. Now, how do you approach such patients? Postural hypotension is a problem, particularly when dealing with elderly and elderly with having multiple comorbidities. Now, The drugs which commonly can cause hypotension, diuretics when you are giving them during the initial periods, alpha blockers, vasodilators, Parkinsonism drugs, the drugs used for prostate. What to do in these patients? First, you ensure that the patient is well in volume, having an optimal salt intake, and check for peripheral neuropathy or autonomic neuropathy. Sometimes there can be both. And the drugs which are good in these patients is the drugs which have a comparatively shorter duration of action, and most of the ACE or ARB fit well into these patients. Another caution which you should take in these patients is that night dose of antihypertensive should be given few hours before sleeping, because postural hypotension is quite common during the morning hours. Now, the SPRINT trial, which have a large number of patients above the age of 75 years, they had two groups. One where there was an intensive lowering of the blood pressure, and where there was a standing lowering of the blood pressure. Although the incidence of injurious falls in the intensive and the standard treatment was the same, but there was a high incidence of postural hypotension, which can be clinically quite troublesome. So for a clinician, it is important to know that in elderly patients, postural orthostatic hypotension is a problem. We should check blood pressure when they come in all the postures and manage according to. And this is one more example I want to give. And this is a 84-year-old male patient, 80 kilograms, 2 prior bypass surgeries. In fact, a physician, a very senior anesthetist. He had diabetes for many years. eGFR is around 30. He had a nephrectomy for a tumor, and so one kidney, LVF, is on a slightly lower side, and his blood pressure remains completely uncontrolled, 170 to 200, diastolics on the lower side. With carvedilol, it's almost 50 milligram a day, nifedipine 60 milligram, did not tolerate amlodipine, and a diuretic. Now, how to treat? These are the real world day-to-day problems. And let me give you some data about the hypertension in the elderly. And this is a very famous HIVET trial. And in this HIVET trial, there were almost 3,500 patients above 80. And it shows that when you treat these patients with indapamide, there is a significant reduction in various outcomes: stroke, mortality, cardiovascular death, heart failure. And this is just showing that, you do benefit when you treat with indapamide. You do a marked reduction in the stroke and in the mortality. But see the caution, what is important. The HIVET trial has enrolled most of the patients which were healthy 80s. This is completely different from what we see in a day-to-day practice. So it's fine. Indapamide is a good drug, but in day-to-day, when you see patients with 80 plus years, there are many patients who are having a lot of associated comorbidities. So the job of clinicians many times is quite difficult. So indapamide is one drug which can be used in elderly patients. And this is another trial, a Japanese trial, which have talked about using renin-angiotensin ARB and ARB plus calcium channel blocker. And this trial also had very elderly population. And the conclusion of the trials was that you can use ARB, or you can use a combination of ARB and CCB. The ARB plus CCB was superior in reducing cardiovascular events in those patients where there was a cardiovascular disease. So those persons where there is a coronary artery disease, you can use a combination of ARB and CCB. In healthy patients, you can use a diuretic. And almost all drugs have shown benefits in very elderly patients also. And coming back to the patient which I showed you, in these patients, our choices are limited. And we have to go ACE and ARB we cannot use. The person is already on calcium channel blocker, is on beta blocker, and is on a diuretic. And we have to go to adding other drugs like moxonidine, cautious use of alpha blocker, and other drugs. And before I conclude, at times a person whose blood pressure was controlled starts having a blood pressure which may be difficult to treat. It's important to remember sometimes atherosclerosis of the renal arteries can come at a later date. Do a renal Doppler, and some patients may be having a significant stenosis of the renal arteries. Then you require to do a renal intervention, as was done in this case. And finally, which drug to use in which, I think it has to be highly individualized. In those who have associated coronary artery disease, diabetes, proteinuria, CKD or heart failure, I think ACE or ARB, calcium channel blockers or diuretics in isolated systolic hypertension, beta blockers, ACE inhibitors if there is a coronary artery disease, and if a person is having advanced CKD, then your choice has to fall on alpha blockers and other drugs. Thank you very much. I think elderly and very elderly is a completely different group of population, and you should individualize the approach in treating the patient. Thank you very much.
Thank you so much, Dr. Satyavan Sharma. I think your talk was quite interesting regarding the elderly treatment, and most of us do not pay much attention to the nature of patient, whether he is elderly or whether he is a young patient. In long run, it's very important to see what should be the modality of treatment in the elderly patients. Any questions from the audience? One or two, because we are falling short of time. Yes, please.
CCBs, will the diastolic will not go shoot further, and in the first case, he is having the his drop in postural hypertension. So have you decreased the amlodipine, or whether you switch to something else? In the first case and second.
If I have heard you correctly, you are telling that if the diastolic pressure has become below 70, which drug you will cut down, right?
Because in the first case, there was a drop in the blood pressure in afternoons.
Say in those patients where the diastolic pressure is going below, and if the patient is having coronary artery disease, those are the patients where we will be very cautious about not allowing the diastolic pressure to go below 70, because the J curve importance is largely in those patients where there is a coronary artery disease. Now, amongst all the drugs, I think the diastolic pressure, most of the drugs which reduce systolic, they reduce diastolic blood pressure. But maybe I think one can approach and reduce the amlodipine dose first and see. That will be a good approach. Yeah, first case, I'm referring to first case. Say, second patient is already on a couple of drugs. When a patient is on a lot of drugs, you continue treating the systolic hypertension. Those are the cases where this issue of J curve really comes into. And sometimes, you have to really draw a balance. You cannot go by the magical figure of 130 or 120 and get the diastolic to 50. So it does become a problem that in some patients where despite multiple medication, particularly when you are looking at patients of coronary artery disease, when the systolic pressure remains, you have to accept it. 130, 140 pressure should be good enough in a person of 75 years where the diastolic has already become 70.
So what is your experience with benidipine new molecule in elderly people?
Pardon?
Benidipine.
Can you come forward, please? We can hardly hear you.
The new molecule benidipine. Benipac that is available.
Benzipril.
No, benidipine.
Benedipine, I don't have experience.
I think no further questions. Thank you so much, sir.
Thank you.
It was a wonderful talk. And the next speaker would be Dr. Dan Lackland. Please, sir. He will be talking on hypertension and stroke, a strong correlation indeed. Daniel T. Lackland is a professor of epidemiology at the Medical University of South Carolina. He has received his doctorate in cardiovascular epidemiology from the University of Pittsburgh. He's a fellow in American College of Epidemiology, American Society of Hypertension, and American Heart Association. He has a long list of achievements to his credit. I'll just rush through them, most of them. He is currently serving on the Evidence Rating Committee of the ACC-AHA Clinical Practice Guidelines. He chairs the Oversight Committee for AHA, Strategically Focused Research Network on Hypertension, and serves on the Data Safety Monitoring Board for serving ongoing NIH-sponsored clinical trials. In addition to these, Professor Lackland is involved in population high blood pressure control efforts. He is Deputy Editor-in-Chief of the Journal of Clinical Hypertension and member of the editorial board of Hypertension, Ethnicity and Disease, Journal of American Society of Hypertension, and Advances in Cardiovascular Therapeutics, as well as serving as the editor of the newsletter of World Hypertension League. He also leads blood pressure and risk factor screening activities at sporting events in Southeast, and many other achievements, sir. Thank you, sir, for coming.
Madam Chairman, thank you very much, and it's very, very nice to be here. I think this is an appropriate place for this to follow the treatment of blood pressure in the elderly, thinking about stroke in the direction that we have. These are my disclosures, which have none financial or there. And what I would like us to talk about is a little bit about the population risk that we see. That's also very consistent with what you see here in India with regards to blood pressure levels, clinical guidelines, but a consideration of what do we want to do with stroke. As a reminder, you see this every day when you go to your practice, the number of people that are having strokes. India is a place that you know is a very high-risk stroke area, constantly right there at the top, leading the area with stroke. You also know this too, and you live it very much strongly. Individuals from South Asia and in the UK were shown to have a greater risk with regards to stroke. So the stroke issue is there. I think it's very, very evident. Just as a quick reminder of some work that we did a while back asking that question, what seems to be the major reason that you're seeing a decline in stroke? What can be the major factor? You already know this, that blood pressure is going to come out and be a player of that. In the early 1970s, this was a prediction model that you've seen over and over again that basically said that for every 2 millimeters of systolic blood pressure reduction, that would correspond to a 6% reduction in stroke mortality. This was a hypothetical model just looking at risks that we're seeing where we're there. Well, this is some work that we did looking at what the population blood pressures have been in the United States. This is very consistent. This is the same things that you were doing over the past several decades when you're controlling blood pressures. Are you lowering the blood pressures of the population? In this case, for individuals 30 to 59 years of age, we indeed shifted the blood pressures to the left, and that was all percentiles, an entire shift over to the left, significant blood pressures. And very importantly, 60 to 74-year-olds that we'll also talk about that's very, very relevant as the direction that we go with regards to stroke, and also for our previous presentation, which was excellent, saying, what do we do with the elderly? This is 60 to 74-year-olds. This is the group that we influenced in the United States the very greatest, in which you saw shifts in blood pressure and population blood pressures by significant amounts of blood pressure. So what happened? If you look at the stroke mortality rates in the United States, you see a decline that's gone over, and actually it's gone over for the past century. But that decline accelerated at the time in which we emphasized blood pressure control in the population. In that early 70s and 80s, that's when we saw the significant decline in which we were saving lives and preventing strokes from actually occurring, and we feel very confident with that. So this leads into the epidemiologist, and I think many in this room would probably say, well, then it makes good sense that what we want to do is to lower blood pressure. But we also have to do it, how much do we want to lower it? We heard some things, and again, a very, very key question that we do have. What is that target blood pressure? And as we've seen throughout the day, if you consider, this is some work that we turned out last year. This is a treatment of hypertension in patients with coronary artery disease. And the question is, what is the target blood pressure for these individuals with regards to stroke? And this is what our recommendation was that. It was that 140/90 was the reasonable secondary prevention for cardiovascular disease in people with hypertension and cardiovascular disease. A lower target blood pressure of less than 130, kind of a traditional thought that we have for individuals with one of these previous other conditions, including stroke. So looking at kind of a 130/80. If you look at the guidelines for stroke and stroke prevention for primary prevention, we've talked about secondary prevention, it's too looking at the 140/90 for primary prevention of stroke, and that's where the recommendations and the guidelines were. As you've heard most of the time, and I think Dr. Ram reminds me constantly that I was on the JNC8 panel, and I was a member, and a proud member of that right there. We came up with the panel members came up with a different recommendation, and perhaps the one that was somewhat controversial, the one that's been brought up at this meeting over and over again. And the statement and the recommendation was, as a reminder, that in the general population greater than 60 years of age, initiate pharmacological therapy to lower blood pressure as to a systolic blood pressure of 150/90. That's the big difference aspect of it. That was the direction that we had. We felt like this was grade A recommendations. What we did call was this corollary recommendation, and that's what some of us felt like were very strongly that should have been made in this. We felt like if you were doing okay with 140/90 and the patient was not being harmed, that would be okay. The issue of that was this was basically expert opinion. As you've heard over and over again, the evidence that you want to establish this was not made, and so that was kind of the controversy that's here. As I was part of the JNC8 panel, I was also part of what we refer to as the minority report, and this was a group of us that felt very strongly that really 150. The question that we had was, if you don't have the evidence, what do you do? Do you just go back to 150 and say we'll wait till the evidence proves us wrong? Or do we say we've been doing pretty good at 140, we've been successful at 140/90, let's don't go back simply because the evidence is not there. And so we pretty much told the individuals, we will stay at 140 until you show us that the evidence that we were wrong with 140/90. So that was a basic statement. I'd like to go through some additional work that's been done and kind of led to this type of conclusion. This is a slide that you've seen. You've actually seen this one today at this meeting. This is looking at blood pressure, stroke, and coronary artery disease, and almost showing you that linear relationship, probably a lack of a J-curve, even though some perhaps have shown this. This is showing a lack of, this is observational data showing a lack of a J-curve, but basically showing also the benefit of lowering blood pressure. Lower blood pressures, lower risk. People that have lowered their blood pressure have a lower risk, particularly of stroke. This is looking at it in just another passion, observational data, looking at, again, linear relationships at every age group. And I think I'd love to discuss it even a little bit more, but from observational data, look at that top line. These are individuals 80 to 89 that would show you that individuals for stroke do benefit at this age with lower blood pressures. Again, the target blood pressure perhaps is what we want to talk about, but still lowering the blood pressure, the lower blood pressure is a lower risk in individuals with 80 years of age and older. If we look at the clinical trials, do the clinical trials show a benefit in stroke, not these composites of outcomes, and including in the stroke, we see consistently all the way through, most clinical trials will show you that if you lower blood pressure, you reduce the risk of stroke significantly, and by very much with about nearly 38%. If you look at, this is some data from the SPS3 study in which they were looking at secondary prevention and looking at a target blood pressure now of looking at less than 130. What this study was able to show that stroke in general, while not quite significant, showed a trend for a benefit, but look where we saw hemorrhagic stroke, just as exactly what you would have expected to see. a very significant reduction and a very significant reduction in secondary stroke prevention with an intense and a stronger lower blood pressure. The other piece of it I think is extremely important that was brought up in the previous presentation, but I don't want to treat somebody and have them have some other types of effects. In this particular case, in the SPS-3 study, you saw no additional serious side effects associated with the treatment of the of blood pressure. Again, some people, when we've done some of our work, we've asked the question: is it a target blood pressure, or is it amount of systolic blood pressure that's lowered? And that's another type of question. This is looking at the amount of blood pressure that's lowered, actually regardless of where you started from with regards to being hypertensive. The blue line is showing that you do see a 33% significant stroke reduction with a 10 millimeter reduction in blood pressure. You see that all the way through. So it's that reduction in blood pressure in the absolute amount. With a 20 millimeter difference, that if you lowered a patient's blood pressure by 20 millimeters, you can expect a 60% reduction, consistent all the way through, but a very somewhat difficult way to kind of look at it. Are we looking at the number of millimeters that you're reducing off of an individual patient, or are you trying to go for an intense for a target blood pressure? This is looking again at the same type. These are consistent factors, and they're consistent with everything else that's been said today. These are some of the major trials looking at long-term blood pressure and within individuals with a prior cerebral vascular disease, and again, consistently all the way through. While some studies were perhaps underpowered and didn't show you significant numbers, you're actually seeing consistently all the way through a consistent pattern where lowered blood pressures have made a big difference as we consider through. These are data from the ACCORD trial that many of you are familiar with and carrying through. And ACCORD was one that truly showed, if you just look at the cardiovascular outcomes, you didn't see the major benefit from ACCORD. But if you looked at stroke, you saw a very significant reduction. The challenge that most of us said, that most of us accepted, was there's still a small number of strokes that were actually occurring. And again, the study was not particularly powered to actually look at stroke, but you saw this great benefit that's here. Which leads us to the SPRINT trial that you've heard much about from some very good speakers and talking about it. In the SPRINT trial, as you already heard, and go quite quickly, you saw the trial was stopped because of the benefit that you turned around and saw. This is actually looking and seeing that tremendous benefit in a short period of time, such that the Data Safety and Monitoring Board said this trial must be stopped. There's benefit from lowering blood pressure to the intensive level. And you've heard that, and that's been there. I would like to focus, though, they didn't show a benefit in stroke. And during this time period, it was the benefits were more in the heart disease and less so in stroke. So now we're seeing particularly heart failure. So now we're saying, ask the question, what might be the case? We feel like some of it's just the number of events that were actually occurring. And if you notice, that is a very, very wide confidence interval that carries through. So we feel like it's an issue of the number of events of stroke that were occurring and not something because it does appear that there is if you look at the absolute statistic, you do see a benefit. We just think it was actual numbers. The other piece of this if we looked at the serious side effects that have already been prevented and talked about, and for the most part, they were not quite as significant. I think when you do look at it by age, I agree with that there are some issues in the older individuals. Summarizing, though, in the SPRINT trial, again, treating high-risk hypertensive adults 50 years of age and older to a target of 120, significantly reduced cardiovascular events by 30%, and all-cause mortality by nearly 25% when you're comparing that to the target of 140. So I think regardless of how it is, probably those thoughts from my panel members of JNC 8 of 150 probably is not staying in this level quite so much. The trial again was stopped because of these very, very strong benefits. However, you still want to, this talk is about stroke. Stroke is what you're interested in. A companion article to the SPRINT results combined the work from Accord with the work from Sprint to try to focus in on what might be the case with stroke. And I'd like to emphasize this, that this is showing again that that intense treatment, when you combine the numbers, and this was consistent that might be the issue of why you didn't see the stroke, the number of events. When you combine the events from the Sprint and the Accord trial, and if you look at stroke, which is the second group that's there, you do see a significant benefit of the more aggressive blood pressure reduction that you would see when you combine the two studies together. Bringing that together, there have been several other systematic reviews and meta-analyses, I think, that have made a great deal of difference that I've considered through. This is one that was just released in 2016, looking at the blood pressure lowering for the prevention of cardiovascular disease. This systematic review showing that stroke, very significant, perhaps the most significant of the outcomes that you could see, the benefit of lowering blood pressure for the prevention of stroke, carrying through there with the third line. If you then look at a similar meta-analysis and some other types of results, looking at the major trials that have been focused in, this is looking specifically at stroke outcomes. If you take it all the way through, the individual trials seem to be confused by the numbers that are there. Whenever we're taking those numbers and we bring it through and bring it into a meta-analysis, notice that statistic at the bottom is indeed significant, brings it through and showing that the heterogeneity was very much in an acceptable level there, and these studies are showing a very consistent pattern in which you're showing a benefit in stroke of lowering blood pressures to the more intensive level. The other piece, though, I think very important to bring up in here, what else did you see? Are you seeing a significant effect? There is some severe hypotension that was mentioned very strongly, a little bit more so in the intensive group. But I think I want to caution you to look at what that prevalence or what the amount is. A very small number of individuals from these 5 studies were actually shown to have the severe hypotension. It was there. It is significant for individuals that have in the more intensive group, but the numbers are so very small that the risk seems to be strongly outweighed by the benefit of treating to the aggressive level. I just want to touch on this to show that it is possible, and I know that you've got some wonderful programs here, and I think you know that it's possible. I'd like to just show a little bit of data from looking at improved blood pressure control associated with these large-scale hypertension programs. This is from the Kaiser Permanente system in the United States, and their focus was to look at the different drug treatment algorithms that they've been able to employ that we've heard a lot about. I'd like to just hit very quickly on this culture of what the improvement was, that they established these quality goal targets that made it very clear and not confusing. And I think that's an important aspect of it, is that we select the goal that we want. They provided performance reports back, very similar to what you're doing here. They have a team that we've talked about who measures blood pressure that makes it very good. They have a risk reduction, again, team that brings it through. They established what the best practice is in much the same way that you're doing right here, right now, and they provide that clinical feedback. This is just kind of showing you that basically that round circle at the top is just showing that they have achieved blood pressure control rates of 70 and close to 80% with this type of regimen. So it shows it can be done, that we can replicate what we're seeing in clinical trials. If we then look and see their benefits that they have, are they actually seeing this, or is this some selection bias? What this particular slide is showing is that this was actually achieved. They were able to achieve in their system a 70 and 80% blood pressure control rates of their hypertensive patients. So it can be done, again, establishing that aggressive blood pressure control. And with that, I'd like to just thank you and on behalf of the World Hypertension League, and know that we're doing some very good things. And I think moving forward, as we discussed a little bit yesterday, World Hypertension Day, May 17th, looking forward in 2017, and I think we can continue to do and continue to make these benefits that we see. So thank you.
Thank you, sir, for such an informative talk regarding the epidemiology of hypertension and the. Any questions from the August gathering? Good.
Comment. Okay, here's your JNC8 question. No, you're sick.
So would you recommend reduction in the population only for hypertensive patients or also the population with normotension?
Yep, wonderful question. As an epidemiologist and as President of World Hypertension League, I think it would be everyone. So clearly, you would establish target blood pressures and lower blood pressures for your hypertensive patients. As was mentioned a great deal yesterday, pre-hypertension is well suited for non-pharmacological treatments, and so you would want a person in the pre-hypertension group to certainly lower their blood pressure, perhaps with weight loss, certainly with sodium reduction. I think we would, to answer your question very specifically, I think everybody would benefit from the lower blood pressure values, particularly for their stroke risk.
Any other question from the audience? Thank you, sir.
Thank you.
Thank you so much.
The next speaker is Anuj Maheshwari. He comes from Lucknow and has been very active in the field of API and RSSDI. He is holding important posts in the UP chapter. He is going to talk to us on proteinuria, a marker of cardiovascular risks. Dr. Anuj Maheshwari.
Yes. Which one? Here first. Wait. Yes, sir. Sorry. There.
Thank you, respected chairpersons, for the nice introduction. I am really taking it as my privilege to speak before Professor B.K. Sahai, who is a father figure for RSSDI, API, as well as ISH, and all the organization related to the medical sciences in India. And I take really it is a privilege to speak before, getting a chance to speak before the WHL President, Dr. Daniel Lackland, our respected Dr. Sunita Tiwari, who has been a head of department in KGMU. So with these words, I have to start proteinuria, a marker of cardiovascular risk. This is the topic of my talk today. In fact, when we talk about the proteinuria as a marker of the cardiovascular risk, it comes to our mind that whether the proteinuria is a culprit or it is CKD, which is leading toward the cardiovascular adverse events, or it is simply a coincidence which is occurring together and giving just an indication that cardiovascular incidences are going to come up. So today's talk we shall be discussing on to finding an answer of these questions. Are they really having similar kind of the risk factors because of what they are coming after each other or coming together? Is that proteinuria is an independent predictor of the combined cardiovascular endpoints? And what could be the take-home message? So first we should like to have a definition of the proteinuria, what we are taking in this context. Proteinuria we are taking as a macroalbuminuria. which is defined as more than 300 milligram urine albumin over 24 hours, or timed albumin excretion in urine as a random spot urine sample more than 200 milligram per 100 ml. Before macroalbuminuria, every patient develops microalbuminuria, which is the beginning of the gross proteinuria. Urine albumin secretion of the 30 to 300 milligram over 24 hours is taken as a microalbuminuria. So proteinuria is a persistent proteinuria, a pathological matter that reflects substantial chronic kidney disease. May I have marker? Oh, there is no point of using marker. Okay. The gold standard for the measurement of the proteinuria is 24-hour urine protein excretion measurement. But now we have got some spot methods also, which do the quantitative measurements with spot urine albumin creatinine ratios. These spot urine measurements correlate very well with the gold standard 24-hour protein quantitation. But variability in the level of the urine protein in an individual from diet, activity, or time of collection is serious limitation of the spot urine test. So, and especially it has got standard deviation up to 40 to 50% from the mean. So we can repeat urine studies, 24 hours urine protein excretion if we have got any doubt. Patients with chronic kidney disease are on the greater risk of the cardiovascular mortality than for the progression of the ESRD. So most of the patients, those who are having the chronic kidney disease, they are more frequently die because of the heart attack and cardiovascular reasons instead of the kidney failure and end-stage kidney disease. In fact, most patients with CKD die from the CVD. Post-hoc analysis of the renal trial, which has shown that is losartan, it was not telmisartan, it was losartan, having any implication in reducing the cardiovascular events in the patient, those who are having eGFR less than 40. Showed that proteinuria more than 3 gram a day with the GFR less than 40 have been associated with the renal endpoint of doubling of creatinine or ESRD in 85% of the patient, with cardiovascular endpoints in only 44% of the patient. But this was the same study which has shown if the proteinuria is less than 1.5, then this difference is not so big. In such conditions, we are having renal and cardiovascular endpoints in 28% and 29% of the patient, means they are the same. It means if we are having beginning of the albuminuria, it is more predictive towards the impending cardiovascular outcome, adverse outcome, than it is in the gross proteinuria. When the patient is a gross proteinuria, the chances of getting ESRD and cardiovascular disease remains almost equal, but when they are less, than chances of getting cardiovascular disease, predictive of the cardiovascular disease is more as compared to the ESRD. Does endothelial dysfunction plays any role in this, or it is playing the major role? Of course, endothelial dysfunction is playing a big role. Microalbuminuria thought to be consequences of the generalized endothelial damage that occurs at vascular tree and glomerulus together. So throughout the body, this endothelial dysfunction is taking place. And this is responsible for proteinuria, as well as this is responsible for the atherosclerosis, which is leading towards the cardiovascular adverse end outcomes. Especially there is an enzyme which is involved in the metabolism of anionic components of the extracellular matrix, that is heparan sulfate proteoglycan, is vulnerable to hyperglycemia, seems to constitute the primary cause of albuminuria and associated complications. But there are certain people, there are certain groups which shows that they are having proteinuria. Some are not having proteinuria despite having in the severe diabetes or for long-term diabetes and having so many risk factors. So this is the genetic polymorphism of availability of such enzymes that really determines the variation of the susceptibility. Who will get this, who will not, this will depend upon the genetic makeup of the person. How does this proteinuria develops and leads to the cardiovascular end outcome. We all know that defects in the glomerular capillary endothelium basement membrane or podocytes is manifested as proteinuria. So what exactly happens? Proteins, hormones, growth factors, lipoproteins, and transferrin that leak into the urinary space and flow to the tubules have been postulated to cause tubulointerstitial injury and inflammation. This injury leads to parenchymal damage, renal fibrosis, and progressive decline in eGFR. And this explains the association of the proteinuria with progression to ESRD, but also suggests the protein in the urinary space is a potential renoprotective treatment target. This is the gross mechanism through which we can understand how does the brain takes over this control of albuminuria through the sympathetic ganglia in the sympathetic trunk, innervating sympathetic nerves, as well as the hormonal control through the arginine vasopressin. Similarly, it also controls the cardiovascular system, especially the heart, through the glossopharyngeal and vagal afferents from high pressure baroreceptors, which actually controls the albuminuria through the ANP and BNP kind of the receptors, and in return angiotensin II release governs the cardiac activities also. And all these three things makes together reduction in the solute free water excretion and reduction in the sodium excretion. And this leads to the adverse outcomes which undergoes in the form of the peripheral vasoconstriction, and at the same time the atherosclerosis as an independent mechanism running into the vascular compartment causes the cardiovascular outcome, and this gives an indication that cardiovascular adverse outcomes are to be there. What can lead to the CV risk? eGFR of less than 60 ml per minute 1.73 meters square for more than 3 months, serum creatinine more than 1.5, presence of kidney damage, microalbuminuria at any level of the eGFR. You can say that random urine albumin creatinine ratio of 30 to 300. So kidney damage for more than 3 months as defined by structural or functional abnormalities of the kidney with or without decreased GFR manifests by either pathological abnormalities or markers of the kidney damage, including abnormalities in the composition of the blood or urine or abnormalities in imaging tests. So markers of the kidney damage, which actually gives the findings of kidney damage into the test. Proteinuria is best reflected by the ACR, more than 30 milligram per gram. Urine sediments abnormality best reflected by the cellular cast, coarse granular cast, and fat. Imaging studies or imaging tests can be done to find out the abnormality of the kidney size, to find out the asymmetry in the kidney size or function. Irregularities in shape like cyst, scar, mass lesion is there, stones, hydronephrosis, and other abnormalities of the urinary tract. Arterial stenosis and other vascular lesions can also be found these imaging studies. Abnormalities in the blood or urine composition can give an idea about the nephrotic syndrome, tubular syndrome, renal tubular acidosis, potassium secretory defects, and renal glycosuria, renal phosphaturia, and Fanconi syndrome can be detected by this. So these are the risk factors for the proteinuria. We know, but just to repeat to all of you, diabetes, mellitus, hypertension, cardiovascular disease, obesity, metabolic syndrome, age and race, kidney injury acutely occurring, malignancy, family history of CKD, kidney stones, infections like hepatitis C and HIV, autoimmune diseases, nephrotoxics like NSAIDs. CKD as an independent cardiovascular risk factors has been postulated in the GNC7. It has recognized for the first time that CKD as an independent cardiovascular risk factor officially. Decreasing levels of the kidney function act as a major adverse prognostic factor after a variety of cardiac events. So CKD in cardiovascular disease. Proper management of the cardiovascular disease is different and more complex in patients with CKD for all these reasons. What the data says, cardiovascular events, hospitalization rate, and death rates are common in CKD those who are having, and in the ratio of their creatinine level and GFR level. So estimated GFR is in reducing, and the rates of the cardiovascular events and hospitalization and death rates are increasing. We have learned a lesson from the Framingham Heart Study that elevated serum creatinine and normal serum creatinine both has been compared, and we could see that elevated serum creatinine people were having more incidences of cardiovascular diseases. Chronic kidney disease have been found to be prevalent into the CVD. In the patients of the coronary artery disease, in the patients of the acute coronary syndrome and congestive heart failure, we could see a good number of CKD patients were there. 45% patients in the CHF, 33% of the patients of acute coronary syndrome were having the CKD, and 23% patients of the coronary artery disease were having the CKD. So both the diseases are running together, and CAD patient, coronary artery disease patient, acute coronary syndrome and CHF all are having a good share of the CKD in them. There is a study, KEEP study, in which the kidney early evaluation program, 37,173 individuals have been screened. They have been of the average age 53 years approx, having the history of diabetes, hypertension or CKD. They have been followed up to the 48 months. Anemia, reduced eGFR and microalbuminuria were independently associated with cardiovascular adverse outcome. And when all the three were present, cardiovascular disease was common and survival was reduced. In another study, 13,826 individuals screened. This was the study in which atherosclerosis risk in community study and cardiovascular health has been evaluated, with the average age of the people 57.6, followed at 3 years interval up to 9.3 years. Blood pressure and serum creatinine have been measured to track decline in kidney function. Cardiovascular disease is independently associated with kidney function decline and with the development of the kidney disease. Traditional risk factors for the cardiac disease we all know are the hypertension, diabetes, age, smoking, dyslipidemia, obesity, inactivity, family history, and left ventricular hypertrophy. How does they contribute in development of the kidney diseases? What are the risk factors in the chronic kidney disease, non-traditional, but are being progressed from the cardiovascular risk factor, like GFR less than 60, like proteinuria, anemia, inflammation, increased CRP, oxidative stress, hyperhomocystinemia, disorders of the mineral metabolism, fluid overload, uremic toxins, electrolyte imbalance, malnutrition, and thrombogenic factors. These all are found in the patients of the chronic kidney disease, and actually they take the patients towards the cardiovascular adverse end outcome. So microalbuminuria is an independent predictor of the combined endpoints. Cardiovascular death, MI, and stroke have been the findings of the HOPE trial, in which this has been finally inferred. Proteinuria is associated with adverse cardiovascular outcome. In the live study, it has been seen the more proteinuria is there, more chances of getting cardiovascular outcomes are. In a preventive study, it has been seen that in a population-based study, more than 9,000 people, presence of albuminuria have been found to be enhancing the predictive value of STT segment changes in a resting ECG for all-cause and cardiovascular mortality. The impact of presence of microalbuminuria on all-cause mortality was greater than other more traditional cardiac risk factors like hypertension, hypercholesterolemia, cigarette smoking, obesity, and diabetes. Proteinuria is associated with adverse cardiovascular outcomes in the live study. I think already this slide has been shown. Going back. Yeah. Microalbuminuria and cardiovascular risk factor. Despite the fact that the Framingham study established in 1984 that proteinuria is an important risk marker of cardiovascular mortality in the general population, albuminuria has never been added to the list of important cardiovascular risk factors. Confirmed by Arnlow et al. And their associate persons with normal blood pressure, without diabetes, and normal GFR microalbuminuria have been found to be a strong predictor of cardiovascular outcome. So if the microalbuminuria is occurring without any of other risk factor, blood pressure is also normal, diabetes is not there, and GFR is also not there, still it can give you an indication that person is more prone to get the cardiovascular outcome. So what life study has shown, reducing proteinuria independent of blood pressure decreased cardiovascular risk. Endpoints were the cardiovascular mortality, stroke, and MI. In the PREVENT-2 study, we saw that patients with albuminuria treated with fosinopril reduced cardiovascular events compared to patients on pravastatin. Renal study has shown patients treated with ARB showed significant decreased risk of the CV endpoints with any decrease in albuminuria. So, chronic kidney disease is a risk factor for cardiovascular disease. It is undoubtedly correct. But proteinuria predicts it on early date. Thank you very much. With these words, I finish my talk and remind you that you should block your date for 24, 25, and 26 March for the DIPSI annual conference, Diabetes in Pregnancy at Lucknow. Thank you very much.
Thank you, Maheshwari, for your very informative talk and the relationship between microalbuminuria and coronary artery disease and its role in prevention. The presentation is open for one or two questions.
Yes, sir. Mike, please.
Yes, sir. Let me ask you about blood pressure measurement and perhaps even on the, not blood pressure, proteinuria measurement, microal measurement in the population, in the general treatment in the population level. What are you recommending, and how would you like to see that being done?
Thank you, sir. Thank you.
There's clearly umpteen amount of data that microalbuminuria and CKD, they are risk factors for cardiovascular death. Has there been a single study to show that if you decrease microalbuminuria, the CV risk decreases?
Pardon?
Is there a single study to show that if you decrease the microalbuminuria, whatever means you give an ACE or an ARB or a angiotensin or an aldosterone antagonist, is there a study to show that decreasing microalbuminuria will decrease the risk factor? Or is it just that it's a marker, not a causative factor?
Yeah, this is a very good question. And in fact, this is the most pertinent for today's talk. In the renal study, it has been seen once the ACE inhibitors has been used in the people, those who were having albuminuria less than 1.5 gram, they have been found to be delayed outcomes as compared to those who have not received. So this was the study, and there have been few more studies like life. I have enumerated in my last but one slide. Life study has shown if you can interfere, although it is very difficult to interfere between the albuminuria, you also know this. It is not really very easy. Only in the microalbuminuria stage you can do something. Otherwise, once the person is in the gross proteinuria, it is very difficult. So if we are talking, my topic is the proteinuria today. If we are talking proteinuria, this can simply be a marker, because at this time, interference will not give much about the cardiovascular risk reduction, but definitely it will delay the end stage renal disease, no doubt about that. So it never means that we should not do that. Cardiovascular risk reduction does not depend simply on the albuminuria correction. It also depends, as Dr. Lackland said, correction of the hypertension, correction of the other risk factors like hypercholesterolemia, atherosclerosis, and other things. So those risk factors should also be required to be taken care, and diabetes is one of the most important out of that. If you are reducing albuminuria by giving the any ARB or ACE inhibitor, but at another end, blood glucose level is very high, you are not keeping safe your patient from the cardiovascular end outcome.
Thank you.
I just want to add there.
There was a recent symposium in the Munich EASD where in the patients in whom the parenchymal changes have not taken place, in spite of the serum creatinine is 1.5, can also reverse back. But the thing is, if there is no, it's a grade 1, no parenchymal change has taken place. When albuminuria is reversed with improved endothelial dysfunction and improved blood pressure, sustained blood pressure maintenance, definitely it can be reversed, and if the albuminuria can be maintained for a longer period. The CV risk factor is definitely reduced because of you are maintaining the other things. That's what the conclusion was there.
Yeah, I agree with you.
Thank you, Mahesh. Our next speaker is Dr. Tiny Nair. He is going to deliver the Professor Muthuswamy oration, workup for a secondary hypertension in clinical client. Dr. Tiny Nair is head of the Department of Cardiology at the PRS Hospital, Trivandrum, and is on the editorial board of Indian Heart Journal, Hypertension and Blood Pressure. He has several publications to his credit, and he has authored a book, Medical Statistics and Happy at Heart. Dr. Tiny Nair, please.
Just before Dr. Nair starts, on behalf of the Indian Society of Hypertension, we would like, since Dr. Nair is going to give the oration for the V.V. Muthuswamy oration, we would like to present him a certificate of appreciation and a medallion. May I request Professor B.K. Sai sir to kindly come over and felicitate Dr. Nair.
Thank you, and please post me a photograph. I can show it to my wife. Good afternoon. It's almost afternoon, ladies and gentlemen. That is Bluma Zeganik. Bluma was a resident in the Department of Psychiatry in 1956, and that was Berlin, Germany. Bluma, on an evening, decided to go out and take her friends to a restaurant for dinner. The large group went to the restaurant and ordered food. What Bluma noted was very interesting. Bluma noted that the waiter who came and took the orders, the waiter did not actually write down anything. The waiter just listened to everyone's order, nodded his head, and moved on to the next gentleman. And a little later, when the waiter came back with the food, it was perfect for everyone, no mistakes. Entire large group served correctly. Bluma was impressed by the super memory of the waiter, thanked him, they tipped him, and then left the restaurant. About half an hour later, Bluma realized that she had left her scarf on the restaurant table. She left her scarf on the table. So she went back to the restaurant, saw the super memory waiter there, and said, oh, I left my scarf. Scarf? What scarf? You remember I was there with the group. Group? What group? He had entirely forgotten her. Then she said, yes, see, I thought you had super memory. You remembered everything that we ordered without a mistake, without writing it down, and now you don't even recognize me. The waiter said, oh, madam, that. Whenever a task is done, I forget that and remove that from my brain. Whenever the task is done, I remove it from my brain, and that is how the entire concept of Zeigarnik effect came in. Zeigarnik went home and wrote his thesis on Zeigarnik effect, and even today it's so very important. And that's the reason why when we write an exam, the very next day, when somebody asks something, we have forgotten it entirely. Look at the TV serials. They stop at a moment. They don't complete it. They stop at a moment where it is not done. So you wait for your next Tuesday evening to switch on the television to know what has happened. Zeigarnik effect. So the point is, when a goal is reached or a task is done, the human mind tends to forget it totally, to dump it elsewhere, and that is Zeigarnik effect. Now, in secondary hypertension, we noted that in the last 5 years, there's steady decrease in the number of cases referred by the GPs as a referral. Not that the number of secondary hypertensions are decreasing, but the GPs are referring much lesser number to us, the specialists. So we thought, is it that the GPs think that secondary hypertension is not important? Or maybe the GPs have stopped thinking at all. Come and write something. Possible, and that is perhaps because their availability of effective and safer drugs. Today the drugs are so effective and safe that every GP can write one after one after one after one, and the blood pressure gets controlled. And perhaps that's the reason why, by Zeigarnik effect, they're not referring cases to us. Possible. Now think about it. When do we suspect secondary hypertension? We always tell that. Remember that skyline picture. What is that? Basically, we say that the hypertension onset has to be sudden. And you see that straight line up. So the hypertension needs to be severe. So sudden onset hypertension, reaching very severe levels, we think of secondary hypertension. Third, resistance. See that flat roof, not responding to my treatment. And number 4, labile. Sudden, severe, resistant, and labile. That picture reminds us of the typical secondary hypertension. At least we suspect secondary hypertension. We also tell and teach people, and we are aware that hypertension, generally essential hypertension, comes between the age of 30 and 55 years. So anything below 30, anything above 55, think of secondary. Sudden, severe, resistant, labile. Below 30, above 55, we think of secondary. In addition to that, whenever there is a target organ damage, be it cerebral, be it retina, be it peripheral vessels, renal, or cardiac, we think of high blood pressure. Secondary cause, especially when it is incongruous or doesn't match with the degree of blood pressure. Target organ damage is significant, blood pressure is not significantly high, or just the other way around, we think of secondary hypertension. The point is, when the GPs think about hypertension, severe and resistant is what they look into. Severe and resistant, please don't show that 15. My talk is for 30 minutes, please. Okay. Okay, right. I won't exceed my time, for sure. So resistant and severe hypertension are the group where the GP thinks that, well, they are controlled, and they don't think that there's a need to investigate for secondary hypertension. And when we talk to specialists, they tell us secondary hypertension is rare. And not only that, with so many safe options available, do you really need to investigate everybody for Little syndrome or GRA or PA? Is there a need? Now remember that the same set of arguments that put forward when Challenger went up in March 1986. $1.7 billion craft, everything was thought to be safe. 73 seconds later exploded, killing all the 7 astronauts. And that was because of a simple problem in the O-ring. So small problem can totally give different outcomes, to which we will come to. And that is why we chose today to talk about the new clinical guide that we are developing, perhaps not for you people who are hypertension specialists, but for people at large, how quickly to at least think about secondary hypertension and diagnose. We say that this new algorithm needs no complicated machinery. It just needs 2 things, your eyes and your ears. How is that? First, we already said you need to diagnose secondary hypertension, sudden, severe, resistant, labile, target organ damage, and age below 30 or more than 55. And then, for the level 1, which is meant for the general practitioners, we say that ask some very pertinent questions, 6 key questions. And all that 6 questions, we can make it into a poster, that's what it's planned for, and put it in the GP's chamber. And now, 6 questions, first 3 are not even for the patient. The first question is your husband, to the wife, actually taking the medicines? And you might come with an answer, no, he is regular, sir, he doesn't take it. Simple, compliance. Second question, does your husband snore at night? And next one would be, does he fall asleep while watching television? Telling us that there might be an OSA underlying as a cause for the secondary hypertension. Question number 4, do you have severe headache during blood pressure rise? We are trying to think in our mind, can there be a pheochromocytoma? Or did you have kidney trouble as a kid? Telling us, was there a polycystic kidney or a CKD? And finally, did you ever have chest pain, claudication, or maybe acute onset breathlessness, flash pulmonary edema? Telling us that, is there a ground to suspect renal artery stenosis? So OSA, pheo, CKD, and perhaps renal artery stenosis. 3 clinical findings are important. We know that anyway we have examined the patient, but most important for diagnosing secondary hypertension with JVP elevation, which tells us nothing but there is left ventricular hypertrophy. In hypertension, elevated JVP tells us there is left ventricular hypertrophy, systolic blood pressure difference in arms and legs, and an abdominal break. Just 5 important investigations. Important because most people think that investigating secondary hypertension is a real headache. You need to send to the specialist. Not really, not really. 1, hemoglobin and creatinine, telling us is there CKD. 2nd, serum potassium, very important. We will spend about 10 minutes on that. 3rd, ultrasound abdomen along with renal Doppler, looking for renal artery stenosis or CKD. And finally, VMA and metanephrine, if you're thinking in the line of pheochromocytoma. So 1, 2, 3, 4, 5 key investigations, and there we are. And with that, we should be able to guess as to what is a problem, and if we have or if we have not, we are thinking of something else, we send it to level 2. In level 2, when the patient comes to us, one of the specialists, first thing that we check is check compliance again. First thing, check compliance again. And that is by either, you can do it in a complicated way by sending blood to some of the few labs that are available in India today who check on urine level of ACE inhibitors, urine level of CCBs, urine level of beta blockers, and they might come out as 0, telling you that there absolutely no compliance to drugs at all. Second thing that we do is, despite an ultrasound being normal, despite the renal Doppler being normal, we do either 64-slice CT angio or we do MR angiogram to look at the renal arteries. Many often we find that there are beaded renal arteries or a significant stenosis of the renal artery which was totally not detectable either clinically or by renal Doppler. And third, we look at the aldosterone-renin ratio, ARR. Now the point is today, most leading labs in large cities in India do an ARR. But we find that the number of people who do ARR are so very rare. ARR is a simple test to interpret, and we would request that do check ARR, because ARR would give you an indication as to how you diagnose, and we will spend a little time on that. The first thing we say is that before you do an ARR, think about 3 things. 1, kidney, 2nd panel, adrenal, and 3rd, the renal tubules. Simple. Take renal problem like the renal artery stenosis or a CKD. So you have a huge amount of renin, you have more angiotensin II, and the adrenal secretes a lot of aldosterone. So in a renal problem, you have a high renin, obviously, and that produces a high aldosterone, and that is the first set. So if you have a kidney problem, basically either a renal artery problem or CKD or a polycystic kidney, you have a high renin and a high aldosterone. The second thing, focus on adrenal. If you have a lot of aldosterone, either a primary aldosteronemia, PA, or a GRA, or a glucocorticoid remediable aldosteronism, and that would obviously increase the aldosterone. As it increases the aldosterone by feedback, your renin is low, and you get the second panel where high aldosterone and low renin. You are focusing on adrenals. And third thing, you have those aldosterone acting onto the collecting tubule, and that collecting tubule has a problem, like its epithelial sodium channels are abnormal, sodium retention takes place more, you have something like Dill syndrome or syndrome of apparent mineralocorticoid excess like same, and you have hypertension there, you have a feedback to the renin, and you have a low renin and a low aldosterone. So finally, let us forget about everything. Where are we? We forgot everything, and we are left with one panel where your renin is high, aldosterone is high, you think of kidneys. Aldosterone is high, renin is low, think of adrenal and aldosterone. Your renin is low, aldosterone is low, think of either Liddle syndrome or syndrome of apparent mineralocorticoid excess. Simple. 1, 2, 3. And we are planning to put again a poster in that so that the specialist doesn't waste time and quickly realizes where he with ARR. We'll just spend 4 unusual scenarios with ARR before we end, because these are situations which might be rare, but you or me might come across them. One, where the ARR, aldosterone-renin ratio, is more than 30:1. So aldosterone is very high. Think of either primary aldosteronemia, PA, or glucocorticoid remediable aldosteronism, familial hyperaldosteronism. The name is changed now, GRA type 1. Okay, so you have GRA and primary aldosteronism, where the moment you hear an ARR is high, you think of adrenals and aldosterone. So aldosterone in nanogram per deciliter, renin in nanogram per ml per hour, more than 30:1. Now again, once we look at the features of primary aldosteronism, textbook could give all that. But let's simplify it. We already learned the features. Already we have learned the features. Features of secondary hypertension: sudden, severe, resistant, labile, age, and of course target organ damage. Let's not revise that. What is important in primary aldosteronism to remember is apart from the point that there's a high ARR, we have hypokalemia. Remember that hypokalemia might present with a muscle fatigue or polyuria and might not be very clear unless we take in history. And if there is a doubt, go in for imaging, either ultrasound, not very sensitive, CT or MRI, to look for an adrenal mass. On the other hand, glucocorticoid responsive aldosteronism, not very common, but unusual. The underlying concept is simple. Zona glomerulosa produces aldosterone by aldosterone synthase. And we have the ACTH stimulating the zona fasciculata, which through 11-beta hydroxylase produces glucocorticoid. That is normal, that's normal. Now in GRA, we have a genetic abnormality where the zona fasciculata through ACTH stimulation tends to produce aldosterone synthase and more of mineralocorticoid. So what happens is we have less of glucocorticoid because the ACTH is just producing more of mineralocorticoid and high mineralocorticoid. So we have hypertension with low glucocorticoid because of abnormality in that the ACTH is acting on the aldosterone synthase in the zona fasciculata. So what happens? High mineralocorticoid, low glucocorticoid. We treat them with glucocorticoid and as a feedback, mineralocorticoid comes down. So that is the basic of GRA. If we look at the features of GRA, again, simple. So we know the features of secondary hypertension, point number 1. Along with that, important are, apart from the high ARR, and of course you can get 18 hydroxycortisols or 18 oxycortisols in urine, the important thing is they will have strong family history. Go and ask the patient of GRA, they might tell somebody else in the family also has very severe hypertension, not responding to treatment. Moreover, these patients, 20% of them suffer from stroke. So you see somebody with a high ARR, they say that many of the family members suffer from that, and there is a family history of stroke. Think of GRA. Treat them with steroids and they would become normal. So how is our clinical flow chart? This is what is simple. So hypertension with hypokalemia, I've done an ARR, found that the ARR aldosterone ratio is more than 30. Good. So we do a CT abdomen. That's the flow chart, simple. And the CT or MR shows an adrenal adenoma or carcinoma, fine unilateral mass. We might find bilateral nodular hypoplasia. Or third, we might find normal. If it is normal, suspect GRA. So if it is mass, it's a mass. Bilateral nodal hypoplasia, you know the diagnosis. And normal, suspect GRA. Think of family history, think of young age of onset, think of stroke. Simple. And then obviously, if you have, that is a picture of a CT abdomen of an adrenal mass. You can see that is a MR, T1 weighted MR imaging of an adrenal mass. And if you have unilateral mass, surgery, bilateral, spironolactone, and you have normal, go for steroid. I mean, you are suspecting GRA, go for steroid. Simple. So we want to keep the flow chart simple so that people don't miss it out. And what about ARR low? So if you have an ARR low, you have two options. Aldosterone is low, renin is low. Either a syndrome of apparent mineralocorticoid excess or little syndrome, leave around CAH because it's very complicated, we're not going to that. Now, syndrome of apparent mineralocorticoid excess is interesting. You have an enzyme called 11-beta hydroxylase dehydrogenase, and that converts cortisol to cortisone. Look at that cortisol. It has an arrow in the head, and that has mineralocorticoid receptor stimulating ability. But the moment it's converted to cortisone, it doesn't have that MRA activity. So in cases where the 11-beta hydroxylase dehydrogenase is absent, you have all those cortisol going and getting attached to the receptor and producing significant mineralocorticoid-like effect. And how do they look like? Again, simple, we said. First line, features of secondary hypertension, don't forget that. Sudden, severe, labile, and all that. And then you have children, poor growth, high mortality. So generally they won't come to your clinic because they die early. Good response to spironolactone and eplerenone, the aldosterone antagonist. That is the key line. But on the other hand, there's no family history. Strokes are rare. But what you might get in your practice would be little syndrome. I believe that a lot of these little syndrome exists, but people don't pick it out because people don't look into it. Again, how do we identify them? Features of secondary hypertension. Hypokalemia with a low ARR, aldosterone low and renin is low. No response to glucocorticoids, unlike GRA. No response to mineralocorticoids, unlike AME or same. Triamterene, amiloride, renal transplant are the treatment of choice for little syndrome. So ladies and gentlemen, the whole point is this. At the end, what we are trying to say is, you should always keep secondary hypertension in mind. Suspect if they're sudden, very high, poor response, labile, and unusual age. Or you have target organ damage far beyond the degree that can be explained by your degree of blood pressure. Point number 2, keep your eyes focused and ears tuned. By simple questioning, even at the GP level, you might be able to make a proper diagnosis of secondary hypertension. Point number 3, don't forget to interview the wife. You might get far more clue than interviewing the patient himself, wife or spouse. 11.1 is basic competence. We'll formulate a simple flowchart, put it in the GP's office so that they don't miss out on secondary hypertension. But most important of this presentation highlight is this. Understand and remember that primary aldosteronemia, glucocorticoid remediable aldosteronism, syndrome of apparent mineralocorticoid excess, and little syndrome don't behave like essential hypertension that we see. Simply controlling their blood pressure doesn't help because they have a different outcome, they're different disease altogether. Unless we understand that, we will fall into the Zeigarnik effect. Thank you for your attention time.
Thank you, Dr. Tiny Nair, for your very excellent presentation. You have told us about when to suspect secondary hypertension and how to approach and arrive at a diagnosis of secondary hypertension.
Thank you.
Ladies and gentlemen, if you have any questions, please be too pleased to answer.
The chairman asked, that is why I asked. I understand that oration generally doesn't have questions. I'm Dr. Edwin from Chennai. I'm a nephrologist. Thanks for the very nice talk, sir. In the basic investigations, I think all of us miss a urine examination. In fact, before doing a VMA or norepinephrine levels, a urine examination will, presence of protein in the urine or RBCs in the urine, will straight away fix a diagnosis of renal parenchymatous disease.
Very important.
So I think a simple investigation, we called urine as liquid gold. It has so much of information that you can give. So a simple urine examination should start off the investigations. Thank you, sir.
I think that's a fantastic comment because this is what we want. We want to develop a module that should be useful for the general practitioners. Yes, liquid gold, fantastic idea. We'll put it next time. I think we should do it. This is assumed that the patient has gone through basic blood checks. You would see that even a blood count is not there. Why we have put it? This is just important point that a person should not miss. Assuming that urine routine must have been done by the GP when he comes, and certainly I think this is very important. We should put it in here.
Thank you.
Thank you, sir.
Hello, one question. Comment.
Yeah.
Hi, excellent presentation.
Thank you.
This is Dr. Rafi from Apollo here. In your workup for adrenal adenoma, you did not mention, I think, the salt loading test, because that's very important to confirm if it's a functioning edema.
Right.
Because otherwise there are incidentalomas and you'll get confused. ARR may not be that.
Correct. Absolutely well. See, this module was not designed basically for the expert who is investigating a person in detail. A unit that is used to handling adrenal adenomas or incidentaloma or whatever kind of thing should only. This was basically for the hypertension specialist and for the GPs not to miss out as they screen and proceed. Absolutely well taken.
I think even for the hypertension specialist, outpatient salt challenge is a very simple test, and they can do it. Second thing, urinary VMA. It doesn't have the sensitivity at all. So it's almost, you can throw it in garbage. When I see it done, nobody does it. In US, I worked at Cleveland Clinic. We never gave any this thing to urinary VMA. So you should go for plasma metanephrine as a screening test.
Yeah.
Thanks.
Rather than VMA straight up metanephrine. Thanks.
Now the next speaker in line is Dr. K.D. Modi, who will be giving us a talk on the ambulatory BP monitoring, who should be targeted. Dr. Modi is a senior consultant, Care Hospital, Nampally. He worked in Medwin Hospital from 1997 to 2014. He's in charge of DNB endocrinology training program at Medwin Hospital, former treasurer of Endocrine Society of India, General Secretary, Hyderabad Society of Endocrinology. He has more than 70 publications to his credit, in which there are 26 original articles, 20 case reports, 8 review articles, correspondences 12, clinical images 6. His major work is in bariatric surgery and diabetes remission. He presented a data in US Endo conference in 2012 at Houston. Presentation was given as a press coverage. Recently, he was awarded a oration in Endocrine Society of India, 2013 Bhopal.